Next talk, characteristics and outcomes of patients undergoing infrainguinal bypass in the endovascular era. Dr. Randall Bloch and Dr. Mark Conrad from Boston.
Hello, and thank you for the opportunity to present our paper, Characteristics and Outcomes of Patients Undergoing Infrainguinal Bypass in the Endovascular Era. We have no disclosures. Peripheral artery disease is a common entity affecting about 7% of adults over the age of 40 in the U.S., and the number of cases of PAD have been rising over the last 3 decades. Among patients with PAD, about 11% will have CLTI, defined by ischemic breast pain and tissue loss or ulceration. Without revascularization, amputation rates are high among patients with CLTI, up to 40% overall and up to 25% in the first year. In 2009, the SVS published a set of objective performance goals for the treatment of CLTI. The results were an aggregate of open bypass outcomes from the control arms of 3 major randomized controlled trials, the PREVENT-3, the CIRCULATE, and the BASIL trials. The goal was to create a benchmark of open bypass outcomes against which endovascular therapies could be compared. However, the results can also be used as a benchmark for which to compare contemporary open bypass results as well. The authors of the objective performance goals established 3 groups of high-risk bypasses that were associated with worse patient outcomes. The first, clinically high-risk bypasses, were defined as those performed on patients over the age of 80 or performed for tissue loss. The second, high-risk conduits, were defined as non-single segment saphenous vein or small vein graft less than 3 millimeters in diameter. And the third, anatomically high-risk bypasses, were defined as those with an infrapopliteal target. The problem is that since the publication of the objective performance goals, there's been an exponential increase in the use of endovascular therapies for the treatment of CLTI, and in fact, recent guidelines recommend reserving bypass for patients with complex anatomy, advanced limb threat, or previously failed endovascular interventions. With that in mind, our hypothesis was that in a contemporary cohort of patients undergoing bypass for CLTI, there would be a high proportion of high-risk bypasses and a high proportion of bypasses performed in patients who previously failed endovascular therapy. Last year, the VESS CLI study was published. This was the largest and most comprehensive randomized controlled trial to date to answer the question of bypass versus endovascular therapy for CLTI. The study contained 2 cohorts of patients. Cohort 1 included those with adequate single-segment great saphenous vein, and Cohort 2 included those without adequate single-segment great saphenous vein. Each of these cohorts were then randomized to receive bypass or endovascular therapy for treatment of CLTI. Their results demonstrated that among patients with usable single-segment great saphenous vein, surgical bypass was associated with significantly less composite major adverse limb events or death up to about 5 years. The objectives of our paper were to characterize the risk of a contemporary cohort of patients undergoing bypass for CLTI, and then to compare our outcomes with the benchmarks published in the objective performance goals and with the results of the VESS CLI trial. We retrospectively reviewed a prospectively maintained database of all patients undergoing bypass for CLTI over a 10-year period at our institution. We then determined the proportion of bypasses that fit each of the 3 high-risk categories from the objective performance goals: clinical, anatomic, and conduit risk. Our endpoints were 1-year limb salvage, defined by freedom from major amputation, 1-year amputation-free survival, which is a composite outcome including freedom from major amputation and death of any cause, and also a major outcome from the objective performance goals. Composite major adverse limb events and death, which included major amputation, bypass revision, thrombolysis or thrombectomy, and this was the primary endpoint for the VESS CLI trial. We then also looked at primary assisted, and secondary patency, both at 1 and 3 years. As you can see from our demographics, a majority of our patients were male and had a smoking history, and many had comorbidities such as hypertension, diabetes, and coronary artery disease. About 38.5% of our bypasses were performed on patients who previously failed endovascular therapy. Amongst our cohort, about 72% of our bypasses were considered to be clinically high risk. About 26% of our bypasses were determined to have used a high-risk conduit, and about 70% of our bypasses were determined to be anatomically high risk. And the thing to note here is the relatively high proportion of clinically and anatomically high-risk bypasses with a relatively low proportion of high-risk conduits used. And here you can see our freedom from major amputation in red and composite amputation-free survival in green over the course of the 1 year, both of which remain high. Specifically, our cohort had a 1-year freedom from amputation rate of 87%, which was statistically equivalent to the 88.9% published in the objective performance goals. Similarly, our cohort's 1-year amputation-free survival was 77.78%, which was statistically equivalent to the 76.5% published in the objective performance goals. The rate of composite major adverse limb events or death amongst our cohort was 43.8%, which was similar to the 42.6% published in cohort 1 from the VESS CLI trial. And here you can see our graph patency. We have primary patency in blue, assisted primary patency in green, and secondary patency in red over the course of a 3-year follow-up period. And here specifically, you can see at 1 year, we had a primary patency of about 47%, an assisted primary patency of about 62%, and a secondary patency about 72%. And then at 3 years, our primary patency was about 38%, assisted was 45%, and secondary was about 61%. So in summary, despite an aggressive approach to bypass for limb salvage with a high rate of distal tibial targets, our cohort was able to achieve satisfactory limb salvage and amputation-free survival at 1 year when compared with the benchmarks published in the objective performance goals. And in addition, our cohort had similar composite major adverse limb events and death when compared with the surgical arm from cohort 1 of the VESS CLI trial. We believe that our outcomes are likely related to careful patient selection to ensure adequate vein conduit, which is also supported by the data from the VESS CLI trial. So in conclusion, our data support the continued use of surgical bypass for limb salvage in patients with CLTI, despite a high degree of tissue loss or a need for distal bypass. Thank you, and I'll take any questions.
I noticed in your group there was about 10% had prior ipsilateral bypasses and about 30% had prior endovascular approaches. Did this come out or affect any of the outcomes in the study?
So we tried to compare those with previous endovascular therapies and those without, and the numbers weren't large enough to really detect a difference. And because the numbers weren't large enough for that, we didn't attempt it with prior bypass.
Great. Thank you very much. Yeah.